Now let's look at dysuria, which is defined as a painful micturition, and it is usually perceived as stinging or burning sensation when passing urine or during micturition. The sensation is usually localized to urethra, but it can be associated with other symptoms which we look into further. Dysuria is more common in women compared to men. In women, dysuria can be attributed to either cystitis or lower urinary infections. These include vaginitis and even urethritis. Patients with cystitis often experience severe dysuria. There can be associated suprapubic pain, fever, usually high grade, associated with chills. There can be urinary urgency, increased frequency. There can also be hematuria. Whereas vaginitis and urethritis usually typically present as dysuria, that is quite limited to urethra itself. In men, dysuria is usually due to sexually transmitted infections or infections of prostate. Infections of prostate can be either acute prostatitis or it can be chronic prostatitis. An important complication of a condition called benign prostatic hyperplasia in men can be urinary obstruction, which can lead to stasis and further lead to bacterial infections causing dysuria. This infection can ascend into upper urinary tract, where it can also cause pyelonephritis and even abscess. In both men and women, there can be non-infectious causes of dysuria. These include lower urinary tract stones, trauma, and urethritis due to topical chemicals. Chronic dysuria, on the other hand, can be due to Behçet's disease, chronic interstitial cystitis, bladder pain syndrome. When diagnosing dysuria among women, approximately 50% of the patients have bacterial cystitis, but this number increases to more than 90% if the patient has dysuria associated with vaginal discharge, increased frequency, and even irritation. Non-pregnant women can be diagnosed with uncomplicated cystitis with the above mentioned criteria, but in pregnant individuals, confirmation with urine dipsticks, urine cultures, and even ultrasonography is required. As dysuria is rare in men, any case of dysuria must be evaluated with urine routine examination, urine cultures, and even prostate examination. The next topic is urinary tract infections. This is a broad terminology which encompasses several conditions: cystitis, pyelonephritis, prostatitis in men, asymptomatic bacteriuria, and uncomplicated urinary tract infections. Asymptomatic bacteriuria is when the urine cultures are positive and there are no symptoms relating to the genitourinary tract. Uncomplicated UTI refers to the urinary tract infection in non-pregnant women without anatomic abnormalities or instrumentation of urinary tract, and complicated UTI refers to all the diseases that do not meet the definition criteria for uncomplicated urinary tract infection. Risk factors for acute cystitis include recent use of diaphragm with spermicide, frequent sexual intercourse, recent history of urinary tract infections, diabetes, and even urinary incontinence. The common organisms implicated in development of urinary tract infections include E. coli, which contributes to 75 to 90% of the cases. Other causes include Staph saprophyticus, which accounts for up to 10 to 15% of the cases, Klebsiella proteus, Citrobacter, and Enterococcus contribute to the remaining 5%, with other organisms being rare cause for bacterial cystitis. When we look at the pathogenesis of urinary tract infections, bacteria usually establishes infections with an ascent from urethra to bladders, and it can even ascend to kidneys, causing pyelonephritis. Whereas Candida species or Candida infections are usually hematogenous. And if Candida species is detected in a non-instrumented immunocompromised host, it can either be due to genital contamination or the patient has a widespread disseminated Candida infections. In clinical features, asymptomatic bacteriuria is considered when urine cultures are positive and the patient has no symptoms. In patients with cystitis, they usually present with dysuria, suprapubic discomfort, fevers, and sometimes even gross hematuria can be present. When there is unilateral flank pain, or in some cases with bilateral flank pain associated with fever, an upper urinary tract involvement can be present. Pyelonephritis usually presents as fever, lower back pain, costovertebral pain, nausea, and vomiting. In patients with pyelonephritis, bacteremia is seen in up to 20 to 30% of the patients. There can be papillary necrosis in patients with obstruction, diabetes, sickle cell disease, and even analgesic nephropathy. Emphysematous pyelonephritis is almost exclusive to diabetic patients, where there is gas formation in renal and perinephric tissues. A xanthogranulomatous pyelonephritis refers to a chronic bacterial infection in a patient with obstruction, usually with staghorn calculi, where this leads to a suppurative destruction of renal and perinephric tissues. Prostatitis can either be due to infectious causes and non-infectious causes, and these patients can present with dysuria, bladder obstruction, urgency, and increase in urinary frequency, along with fevers which are high grade, and even pelvic or perineal pain. In diagnosing UTI, patient's history has a very high positive predictive value. In diagnosing urinary tract infections, history has a very high positive predictive value, and with a history of dysuria and urinary frequency, the likelihood of UTI reaches 96%. An examination may reveal high grade fever, suprapubic tenderness. There can be associated vaginal discharge or urethral discharge. Patients with pyelonephritis can have costovertebral angle tenderness. Additional tests include urine dipstick, which can be positive for nitrates or leukocyte esterase, but urine culture and sensitivity remains the gold standard when diagnosing UTI. In female patients with symptoms of cystitis, a colony count of more than 10 to the power of 2 per ml is highly sensitive in diagnosing urinary tract infections. For asymptomatic bacteriuria to be called significant, more than 10 to the power of 5 colony count per ml. Let's look at the treatment for urinary tract infections. There are various antibiotics used in the treatment for uncomplicated cystitis in women, and these include nitrofurantoin, trimethoprim sulfamethoxazole, fosfomycin, pivmecillinam, fluoroquinolones, and even beta-lactams. Nitrofurantoin is given in the dose of 100 milligrams twice daily for 5 to 7 days. Trimethoprim sulfamethoxazole is given as double strength, that is 160 over 800 mg, given twice daily for 3 days. However, it is important to note that this combination should be avoided in places with resistance more than 20%. Fosfomycin is given as a single dose of 3 gram sachet. Pivmecillinam is given as 400 milligrams twice daily for 5 to 7 days. Fluoroquinolones have varied dosing, but is usually given as a dosing regimen for 3 to 5 days. Beta-lactams also have varied dosing, and they are given for 5 to 7 days. Fluoroquinolone usage is restricted to places where other antibiotics are not available or show resistance. Fluoroquinolone usage is associated with high resistance rates and patients are at higher risk for Achilles tendon rupture and also irreversible neuropathies. For treatment of pyelonephritis, fluoroquinolones are first-line agents. For example, ciprofloxacin is given as 500 mg oral dosing twice daily for 5 to 7 days. And if the bacteria is sensitive, for trimethoprim sulfamethoxazole, then it is given as 1 tablet double strength twice daily for 14 days. But with increasing resistance, this is usually avoided. In patients with UTI in pregnancy, nitrofurantoin, ampicillin, and cephalosporins are considered safe even in early pregnancy. Let's look at treatment of urinary tract infection in men. An uncomplicated infection can be treated with either fluoroquinolones or trimethoprim sulfamethoxazole given daily for 7 to 14 days. In patients with acute bacterial prostatitis, patients can be initiated on antibiotics, preferably after obtaining blood and urine culture samples. And treatment is usually required for 2 to 4 weeks. For chronic bacterial prostatitis, patients may require treatment for 4 to 6 weeks. Asymptomatic bacteriuria should be treated only in pregnant women or in women with planned urological surgeries, in renal transplant recipients, in neutropenic patients, and immunocompromised. In pregnancy, it is treated with antibiotics for 4 to 7 days and it is guided by culture and sensitivity patterns. Next, we'll look at treatment for catheter associated urinary tract infections. Urine cultures are very important to guide the therapy. Patients with suspected catheter associated urinary tract infections require replacement of catheter. Candiduria is seen in patients with indwelling catheters and it resolves in 1/3 of the patients after removal of catheter. Treatment of candiduria is with fluconazole given in the dose of 200 to 400 milligrams per day for 2 weeks. This is usually initiated in patients with cystitis or pyelonephritis or patients at risk for disseminated infections. When it comes to prevention of recurrent urinary tract infections, women experiencing more than or equal to 2 episodes of urinary tract infections per year are candidates. And this preventive therapy can either be given as continuous therapy, post-coital therapy, or self-initiated. In continuous and post-coital therapy, the choice of agents include low-dose trimethoprim sulfamethoxazole or fluoroquinolones or nitrofurantoin. Whereas patients who are being self-initiated should be provided kits for urine culture and they should be provided with antibiotics that needs to be initiated at the onset of first symptom. As a general rule, in the absence of anatomic abnormalities, the prognosis of urinary tract infection is good, and chances of pyelonephritis or renal failure are very less. Next, we will look at bladder pain. Bladder pain is perceived as a suprapubic pain that is associated with altered urinary bladder filling and emptying, and there can be urinary symptoms of urgency and increased frequency. Acute bladder pain, which usually lasts for less than or equal to 2 days, is usually associated with bacterial cystitis, whereas chronic bladder pain can be associated with chronic or recurrent bladder or ureteric calculi, pelvic cancers, urethral diverticulum, radiation cystitis, tuberculous cystitis, neurogenic bladder, bladder outlet obstruction, urogenital prolapse, and even benign prostatic hyperplasia. Next, within the bladder pain is bladder pain syndrome. It is also known as interstitial cystitis. Etiology for interstitial cystitis remains unknown. Possible etiologies include chronic bladder infections, effect of inflammatory cells such as mast cells, even autoimmunity, or increased permeability of urinary bladder mucosa, or increased sensitivity to pain. Symptoms include pain, urinary frequency, urinary urgency, and even nocturia. The pain can either be in bladder, or there can be vulval or urethral pain also. It is common to have pain at 2 or more sites, including non-urogenital areas. Classically, the pain is increased on bladder filling, and pain drastically decreases on emptying. The urinary frequency in these patients is on an average approximately 10 times per day, but it can reach a maximum of even 60 times of urination per day. Many of the patients with interstitial cystitis have comorbid conditions which can be functional somatic syndromes, including fibromyalgia, irritable bowel syndrome, and chronic fatigue syndromes. Diagnosis is based on symptoms plus exclusion of other causes. Physical examination and lab findings are non-specific and insensitive. Cystoscopy may reveal an ulcer in approximately less than 10% of the cases, or there can be petechiae that are seen on cystoscopy after bladder distension. However, both the findings are again non-specific. The goal of therapy in these patients is reduction of pain, and patient usually requires multifaceted approach, including patient education, stress reduction, treatment with analgesics such as NSAIDs, or medications such as amitriptyline, dietary changes, pelvic floor exercises, and physical therapy treatment for coexisting functional somatic syndromes. Next, we will look at nephrolithiasis. Renal calculi are common and they affect approximately 1% of the population, and it is recurrent in more than 50% of the patients. Stone formation usually begins when the urine becomes super saturated with insoluble components. These can be due to low urine volume, increased or reduced excretion of some compounds. Other factors such as urinary hydrogen ion concentration or pH, which affects the solubility, and even infections that can alter the above three. When it comes to the composition of the stones, there can be either calcium based stones, including calcium phosphate, calcium oxalate, or mixed calcium stones. There can be struvite, which is magnesium ammonium phosphate, uric acid stones, and even cystine stones. Calcium based stones contribute to 75% of the cases, whereas struvite is a cause for 15% of the cases. Uric acid contributes to 5 to 10% of the cases, and cystine stones are approximately 1% of all the cases. The clinical features vary according to the location of calculi. In patients with stones in renal pelvis, patients can be asymptomatic, or sometimes they may have hematuria. When left unchecked, it may cause pain when it passes into the lower urinary tract or obstruction to the urine flow. This passage and obstruction leads to a severe pain, usually radiating to groin, and it is associated with visceral symptoms such as nausea, vomiting, lightheadedness, and diaphoresis. Apart from these, there can be associated hematuria, urinary tract infections. Rarely, there can be hydroureteronephrosis due to obstruction. An important thing to note about struvite stones is that it is associated with recurrent urinary tract infections with urea splitting organisms, and these include Proteus, Klebsiella, Providencia, Morganella, and other organisms. Let's look at the stone compositions. The most common ones are calcium oxalate, which is associated with hypercalciuria or hyperoxaluria. Hypercalciuria can be seen in patients with high sodium diet, loop diuretic, type 1 distal renal tubular acidosis, sarcoidosis, Cushing's syndrome, aldosterone excess, or in cases with hypercalcemia due to hyperparathyroidism, hypervitaminosis D, or milk alkali syndrome. Hyperoxaluria is seen with intestinal malabsorption, especially in ileal diseases and inflammatory bowel disease, pancreatitis, and conditions with increased absorption of free oxalates. The pathophysiologic factors implicated in formation of calcium oxalate stones include deficiency of urinary citrate, which is an inhibitor of stone formation, and this is under excreted in patients with metabolic acidosis. And the second factor is hyperuricosuria. Calcium phosphate stones, on the other hand, are quite rarer, and they are formed in abnormally high urinary pH of 7 to 8, and it is usually associated with partial or complete renal tubular acidosis. The next important type of stone is struvite stones, which are formed by magnesium ammonium phosphates. The stone is usually formed in collecting system where a urea splitting organism causes an infection. Struvite is the most common component of stag horn calculi, and these cause renal obstructions. There are several risk factors for struvite stones, including recurrent urinary tract infections, urinary catheters, non-struvite stones, neurogenic bladder in conditions such as diabetes mellitus and multiple sclerosis, and even instrumentation. The next type of stone is uric acid stones. These are formed when the urine is saturated with uric acid in the presence of an acidic pH in the urine. Patients usually have a metabolic syndrome and even insulin resistance. Patients can have very high uric acid turnover in conditions including psoriasis, cancers, gout, and even uricose uric agent therapies. In gout, there is a relative defect in ammoniogenesis. This leads to a very acidic urine with a pH as low as 5.0. Patients with myeloproliferative disorders, other causes of secondary hyperuricemia and hyperuricosuria due to increased purine synthesis can have uric acid stones in presence of diminished urine volume or concentrated urine. Medications that cause hyperuricosuria include salicylates and probenecid. The next type of stones are cystine stones. These are the result of a rare type of inherited disorder where there is a defect in renal and intestinal transport of dibasic amino acids, as a result of which there is an increased excretion of cysteine, which is relatively insoluble and leads to stone formation. Cysteine stones are more likely to form in acidic urine, and they are a rare cause for staghorn calculi. These stones are typically seen from childhood, and sometimes they can even progress to end stage renal disease. In evaluation of renal calculi, taking a thorough history of fluid intake and diet plays an important role. There needs to be a detailed physical examination to look for systemic diseases. In radiological investigations, non-contrast helical CT scan with 5 mm cuts is preferred. Routine urine analysis can show hematuria, crystals, and measuring the urinary pH can yield information about the type of stones that are being formed. Blood chemistries include serum calcium, uric acid levels, bicarbonate, arterial pH, serum creatinine, parathyroid hormone levels, and even chloride levels play an important role. Urinary electrolyte and mineral levels can be calculated by 24-hour collections of urine. In case of staghorn calculi, patient's urine culture can reveal urea splitting organisms. Let's look at the treatment for nephrolithiasis. Treatment for the most part is empirical. As a general rule, an increased fluid intake to 2.5 to 3 liters of water per day is the most effective intervention, regardless of type of stones. Specific therapies for different stones are based on the type of stones that are detected. For calcium oxalate stones, dietary modifications such as increased fluid intake, reduced sodium oxalate, and even reduced or moderate protein intake and reduced fat intake are recommended. Patients can be treated with citrate supplementation, which reduces the likelihood of formation of stones. In place of sodium salts, patient can be given calcium or potassium salts. Cholestyramine can be given for patients with fat malabsorption. Patients can be given thiazide diuretic if the patients are hypercalciuric, and allopurinol in cases with hyperuricosuria. For calcium phosphate stones, again an increased fluid intake with reduced sodium intake is beneficial. Patients can again be treated with thiazide diuretic if hypercalciuric. If there is hyperparathyroidism that needs to be treated, patients should be treated with alkali in cases with distal renal tubular acidosis. For patients with struvite stones, they will require increased fluid intake And if there is evidence of oxalate stones as nidus for struvite stones, then the treatment is similar to calcium oxalate stones. Specific therapies include methenamine, vitamin C given daily. Patients can also be treated with antibiotic suppressive therapies, trimethoprim and sulfamethoxazole. The next type of stone is uric acid stone, where again patient needs to have increased fluids and reduced dietary protein intake and avoidance of red meat. Specific therapies include treatment with allopurinol, and patients can be treated with alkali therapy by potassium citrate with an aim to increase the urinary pH to more than 6 to 6.5. Cystine stones need increased fluid intake, and patients may also require penicillamine or alkali therapy. The next topic is urinary tract obstruction. Urinary tract obstruction is a potentially reversible cause of renal failure, and it should be considered as a differential in any case with acute or abrupt decline in renal function, or even in patients with worsening of chronic kidney disease. The clinical manifestation is dependent on duration of obstruction and whether the unilateral or bilateral involvement is present. The obstruction can be at any level from collecting tubule to urethra. Important causes for urinary obstruction in women include pelvic tumors. In men, it is possibly due to prostatic enlargement. In patients who have diabetes, there can be associated papillary necrosis, which can be a main reason for urinary tract obstruction. And other causes include neurogenic bladder in patients with spinal injury or multiple sclerosis, patients with retroperitoneal fibrosis or lymphadenopathy, vesicoureteric reflux, nephrolithiasis, and functional urinary retention, which is caused by anticholinergic drugs, can also have urinary tract obstruction. In clinical features, patients can complain of pain, which can be due to obstruction secondary to renal calculi. However, men do not usually complain of pain, and there can be associated lower urinary tract symptoms such as hesitancy or urgency or even nocturia. Examination can reveal a large urinary bladder in cases of post bladder obstruction, where percussion in suprapubic region can reveal a dull note. Ultrasonography can help in identifying post void residual urine. Digital rectal examination can reveal prostatic hypertrophy. Bimanual examination in women can reveal pelvic masses or rectal masses. In patients with longer duration of obstruction, there can be associated tubulo-interstitial pattern of abnormalities, and these include hyperkalemia, mild hypernatremia, and non-anion gap metabolic acidosis. Obstruction secondary to stone can be revealed by helical CT scans or abdominal radiography. Ultrasonography can be used to assess for hydroureteronephrosis and integrity of renal parenchyma. In localization of obstruction, CT or IV urography can be employed, which usually reveals a calyceal dilation that is absent in cases of hyperacute obstruction. Even upper urinary tract encasement by tumor or retroperitoneal fibrosis or even stag horn calculi can be revealed by CT or IV urography. For functional assessment of obstruction, a nuclear scan with radioisotope technetium 99 multiatide, known as technetium 99 MAG3 scan, before and after the administration of loop diuretics can be done. An important thing to note is that unilateral obstruction can go unnoticed and may cause permanent irreversible damage without any evidence in physical examination and biochemistries due to compensation by normally functioning kidney. So in a patient with unexplained renal failure with evidence of bladder or prostate enlargement or evidence of tumor with a inconclusive urine analysis, suspect a urinary tract obstruction. In these patients, insert a bladder catheter, and if the patient has diuresis, then the obstruction is below the neck of bladder, and if there is no diuresis, then subject the patient to renal ultrasound. Renal ultrasound can reveal a hydroureteronephrosis where obstruction is above bladder neck, or there can be no hydroureteronephrosis. In patients with evidence of hydroureteronephrosis, the site of obstruction needs to be assessed and relieved. This can be done by anterograde or retrograde urogram. Patients can also be subjected to CT urography. In patients with no hydroureteronephrosis, if there is a high clinical suspicion of urinary tract obstruction, patients can be subjected to anterograde or retrograde urography, and if the clinical suspicion is low, then patient can be evaluated for other causes of renal failure. Now let's look at the management of urinary tract obstruction. The management of renal failure is influenced by the level of obstruction, that is whether the obstruction is in the upper urinary tract or lower urinary tract, and the acuity of obstruction, including its clinical consequences. Benign causes such as bladder outlet obstruction can be relieved by Foley's insertion, and nephrolithiasis can be treated by IV fluid administration. In patients with tumor compressing the urinary tract and causing urinary tract obstruction, cystoscopic assessment and placement of urinary tract stent is preferred whenever it is possible, and if that is not possible, placement of nephrostomy tubes with external drainage can be done. In patients with pyelonephritis or urosepsis, patients should be treated with prompt antibiotic therapy and usually guided by cultures and local resistance patterns. Patients with idiopathic retroperitoneal fibrosis can be treated with ureteric stenting and immunosuppressive therapy, including prednisolone, mycophenolate mofetil, and even tamoxifen. Post relief of obstruction, patient should be closely monitored with special attention to urine and serum electrolytes. Patients can have relative diuresis or natriuresis, which can be due to volume overload. This can also happen due to an increased blood urea levels, or in cases of acquired nephrogenic diabetes insipidus, where there is osmotic diuresis leading to severe hypernatremia. Urological references need to be obtained in all cases of urinary tract obstruction. With this, the rapid revision of nephrology comes to an end. All the best for your exams.